Now today we welcome Dr. Parapia. Dr. Parapia, may he be sworn, please?
Please state your full name.
Liakat Parapia.
And repeat after me. I swear by Allah
I swear by Allah
that the evidence I shall give
that evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth. Thank you.
Professor Parapia, I'm going to start asking you some questions about your CV. So you undertook your medical training in the early 1970s at the Welsh National School of Medicine. Can you recall? Is that right?
Yes, that's
yeah.
right. Yes.
Can you recall what kind of haematology training you had?
Well, Cardiff, the Welsh National School of Medicine, was very, very strong in hematology, very reputable, some very big names at the time, including Professor Bloom. Even I was taught by Professor Tuddenham. But in terms of actually content of the training for the medical school, there was very little time given for hematology.
And so you said you taught by Professor Tuddenham at university?
Well, in the component that he had, yes. So I knew him from then. But like I said, in terms of the curriculum, there was very little hematology.
And then you graduated in 1974 and you became a house officer at the Cardiff and Carmarthen Hospital, and the following year senior house officer at Wythenshawe Hospital in Manchester.
Yes, that's right, yeah.
And during your time in those two posts, did you treat any haemophiliacs?
No, none whatsoever.
And then you took up a role as a senior house officer in pathology at the Wythenshawe Hospital. What did that involve?
Well, first senior house officer in medicine, general medicine, I did a medical rotation. And then I did pathology rotation as the senior house officer. That means I went through all the components, including hematology, for 3 months. And then I became registrar in hematology, combining my medical and my pathology training together. And by this time, I had the membership of the Royal College of Physicians.
And so that you became a registrar in 1977, and that was again in the Wythenshawe Hospital in Manchester.
That's right, yes.
And at that stage, so while you were working there in haematology and doing your pathology rotation, were you caring for any haemophiliacs in the haemophilia centre?
No, none at all. There was no haemophilia centre there. There's a good cardiac unit, etc. But no, haemophilia was being treated at Manchester Royal and at Withington Hospital, or the coagulation disorders.
So you had no experience at that stage of dealing with anyone with haemophilia?
No, none at all.
And then in August 1978, you became senior registrar in haematology between Leeds and Bradford, and you held that post for 3 years.
Yes, that's right, yes.
And you rotated between the two, between Leeds and Bradford, did you?
Yes, the rotation was divided between Leeds General Infirmary, St. James's Hospital, which was the haemophilia centre, blood transfusion service for 6 months, including pediatrics, and the time at Bradford Royal, which was a haemophilia centre.
And when you were at the blood transfusion service, what did that involve?
That was combined with pediatrics. We learned about bench work, but I think largely we were really a pair of hands. There was very little what I would call formal training, but we were apprentices to the consultants.
So you were, and where physically were you during that period?
At Blood Transfusion Centre in Leeds.
In Leeds.
Near Seacroft, you know.
And primarily in the laboratory there?
Primarily in the laboratory sort of setting, but we were also doing pediatrics at the same time. So we did the pediatric bone marrows, etc. You know, sort of giving support to the pediatric oncologist.
And while you were in Leeds at St James's Hospital and at Bradford, were you working in the haemophilia centres there?
Yes, but the primary focus in both hospitals was to do with chemotherapy and leukemias and, well, in Bradford, solid tumours, lymphomas and so on. But the haemophilia care was there, yes, and that's where I got my experiences, yes.
So your first experience of working with people with haemophilia was in 1978?
In 78, I started at Bradford, where the senior registrar really was primarily involved in treating haemophiliacs. And then at St. James's, again, it was really the junior staff that treated the bleeding disorders.
And who was the director of the Leeds Centre at that time?
Dr. Swinburne she wasn't a hematologist, she was an immunologist. And she wasn't a clinician, but she was in charge of hemophiliacs.
In the Leeds Centre?
In Leeds, yeah, at St. James's.
And then in the Bradford Centre it was Professor Turner, is that right?
Yes. It was Professor Turner who, by the way, set up the first haemophilia centre in the country. It was in Bradford, so he was quite instrumental. And his early days, he did a lot of work with coagulation, especially with factor 13 and so on. But his main focus was to do with oncology. His professorship was to do with oncology and University of Bradford. But yes, we had a haemophilia centre there, and the laboratory staff were excellent there, actually, in terms of teaching me about coagulation, etc. You know, I mean, really, I'm very grateful.
And then in 1981, you were appointed consultant at Bradford. Is that right?
Well, Professor Turner was taken ill, and I'd just passed my MRC path, and within 2 weeks we were on holiday, and I was informed that he was ill, and would I take over? But I was a senior registrar, so in effect, I took over as locum consultant, but also effectively in charge of the department there. And I would be the locum director of the haemophilia centre as well. But we lost staff. I was a senior registrar, became locum consultant.
And so that, as you described, happened rather suddenly. So,
very suddenly.
And you were only 32 or something at
30,
that stage?
31.
31.
And it was 7 years post-qualification. So I was one of the youngest consultants in Yorkshire, but treating both hematology and oncology. So I was also treating solid tumours, breast cancers and so on.
So you suddenly in 1981 are appointed consultant and effectively acting director of the centre.
That's right. And
does Professor Turner ever return to his role as director of the centre?
Well, he came back for a couple of weeks and then he retired totally. And by that time I had the interviews and I was appointed to substantial post in 1982.
So although it says on your CV, appointed centre director 1982, in fact, you were carrying out that role from 1981.
Yes, I was, yeah.
And you mentioned that you were also carrying out a role in oncology. Can you give us an idea of how much of your working week was divided between your role as an oncologist, hematologist, and your haemophilia care in that early period?
It was a very tough time for me because I was doing too many jobs, basically. There were only 2 consultants. 2 of us for a size city of Bradford, you know, which is, I would have said...
Sorry, 2 consultants for in what? In what specialty?
Well, one in hematology, and
yes.
I became the hematologist
yes.
stroke oncologist. I was actually then accredited in oncology, which there were very few people in the country who were both accredited in both specialties, you know, but purely by accident, I think. But in terms of how much time I spent, most of my time, probably 90% of the time was spent to do with chemotherapy and hematological malignancies and solid tumours. small amount of time spent with hemophilia care or coagulation. And I think we'll talk probably more about it, because coagulation disorders was a very big thing in Bradford, but not necessarily hemophiliacs.
And so you're split 90-10
Possibly,
in those early
yeah.
years, possibly. I mean, I understand it's a long time ago, is your best estimate in those early years. And did that remain the case through your life, or did that working life, or did that change as the years went by?
Well, as years went by, I wanted to give up the oncology because I really hadn't formal training. But it was an impossible job for anybody to all do all that. So we agreed with the Trust and Health Authority. They were going to appoint a third hematologist, but that we agreed that should become an oncologist. So it was the first medical oncologist in Yorkshire was appointed in Bradford. Pure medical oncologist, not radiotherapy. And so I dropped the oncological work and did hematology and the director Haemophilia Centre. But the cost of that was that I was only given 4 beds, clinical beds for hematology and for hemophilia work. It was grossly inadequate, you know. But that, I think, as my story evolves, we started a charity, Annette Fox Leukemia Fund. We started gathering money. We built a unit which then could also treat both the leukemias and so on. But at the same time, we could have a place where we could treat people with coagulation disorders. And also at the time, we tried to enlist Dr. Minford, Adrian Minford, pediatrician, to try and help me to look after the children, because I wasn't qualified for that. I had no pediatric training. But we were very lucky because we were able to build up a team and so on. Sorry, I'm carrying on a bit.
That's quite all right. Just going back then to when you think you dropped the oncology and you got the oncologist, the third consultant. When do you think that was?
Probably, I think, in 84, 85, something like that.
And so then you had more time to spend on the centre than you had before. Is that right? That was the idea, presumably.
I never had enough time. Ever. Until I retired.
And then, Professor Parapia, you also, in amongst all of that, were carrying out various teaching and academic roles with the Leeds Medical School and with the director between 91 and 96 of postgraduate education at Bradford Teaching Hospital.
Yes, I tried to. We tried to get into research. We tried, like you said, I tried to build a team. I built links with University of Bradford, which is where I got my visiting professorship. I started hemostasis thrombosis unit there as well. One of the things, I think it's often not realized, it wasn't realized by managers or, health service or UKHCDO and so on. Bradford had a large population of Pakistani immigrants. And one of the things about them, including in other places like Birmingham and so on, was there was a lot of consanguineous marriages. And so we had children, and some adults, but largely children, who had very rare disorders that even now haven't been fully recognized. So although hemophilia had a greater impact because of the amount of money we spent, and Haemophilia Society and UKHCDO and so on, but we had a large number of people with bleeding disorders that made up our center, and it took up a lot of our time. And as from my publications and so on, you would have seen that we had rare platelet disorders. We had factor 13 deficiency, and Dr. Minford gratefully, and protein C deficiency, and Dr. Minford gratefully got into partnership, and we produced a lot of research and papers based on that, which is one of the reasons why I always felt that UK Haemophilia Centre's directors, that we were a big center, short of resources and staff, but never got that acknowledgement as the reference centers did. So it was one way of getting resources if he had been upgraded, but we managed.
And then you continued in those roles until your retirement in 2009.
Yes, in between, like you said, you see, one of the important things was to keep our staff. And there was always this pressure that because we were in proximity to Leeds and so on, that the senior registrar and the registrar training should be taken away from Bradford. So we had to build a department so we could retain. So we did have, made sure that we were training people, carrying out research. We made sure that the registrars and senior registrars got proper formal training, and they produced papers, etc. We tried to get resources, money, and built a ward. My wife was a trustee as well, and we raised money. But in order to keep our department intact with staff and resources, we had to build links. And so in the later years, I became one of the sub-deans at Leeds Medical School, an honorary senior lecturer, etc. I mean, there's a whole load of appointments that I had. I was director of postgraduate education in Bradford, and then obviously I was an examiner at various colleges and so on.
And then you had your first meeting that I've been able to find of the UKHCDO, so annual directors meeting. You attended was in November 1979. So that is when you were a senior registrar in Leeds and Bradford. Does that sound right to you?
Unusual for a senior registrar to have attended the UKHCDO meeting, but I can't remember it. But if you got it there, it's obviously there,
So there's a record of you attending on November 1979, October 1981, and that's when you've described that you were de facto centre director,
yes, right.
albeit not yet appointed. And then from then on, you were a very regular attender. I think there's only one year that I've identified that you missed. Does that sound right?
Very important meetings to attend, because that's where we often got our information. Incredibly. I've got all the minutes for every year, but they were so you could meet colleagues as well. Very important indeed.
But you never held a role on any of the working party groups. And as you've described, you were never a reference centre director, so your attendance was limited to those annual general meetings.
Yes, although after a few years, there were working parties for platelet disorders and rare coagulation disorders, and we produced guidelines. But they were not the main workings of the UKHCDO. No, I wasn't in the executive or within the inner circle, as one would say.
You very kindly shared some of your papers with the inquiry, and in there we find minutes of working party groups, reference centre director meetings that you didn't attend, but you seem to have the minutes. Can you recall how you got those minutes?
I usually try to attend all the meetings of the wider UKHCDO,
yes.
but obviously they're the UKHCDO reference directors meetings, which I couldn't attend.
No, but do you seem to have the minutes? Do you recall how you got the minutes?
Well, I presume they must have been sent to me. I think they would have been circulated.
And do you have a recollection of getting regular minutes of meetings of reference centre directors and so on?
I tried to get minutes of most meetings because we were all desperate for knowledge to make the best decisions. We needed information. Now, any source of information, whether it's for UKHCDO, from pharmaceutical companies, from regional meetings or lectures, international meetings, we would try and get that information. If it was written, and I kept quite a lot of it, I still have a lot, by the way, that you could have. So yes, I must have received much of these,
That you also mentioned in your witness statement that there were other committees that you were members of, and in particular a member of the regional haemophilia group in Yorkshire. And from one of the documents that we'll go to in due course, there's a list of attendees. And I just wonder if you have any recollection yourself of who would attend those meetings.
Well, Leeds was the largest centre.
Yeah.
We were the second largest in terms of haemophiliacs. But other, see, it was a bit complicated because you had the haemophilia centre, then at that time you had associate haemophilia centres. I think the idea was to have the haemophilia centres, so it was like York and I think Harrogate. Hull was reasonably big. But then you had the associate. Now, I can't remember which ones were which. But Huddersfield may have been associate. But I really can't tell you how the membership was organised.
So the minutes of this particular meeting suggest that you were there, Dr. Swinburne was there from Leeds, Dr. Tovey, I understand he was from the Regional Transfusion Centre.
Yes, he was the director of the regional transfusion.
Of the Yorkshire Regional Transfusion Centre, was
right,
it?
Yes.
Dr. A. Robinson.
Yeah,
Angela Robinson from the blood transfusion service.
Yes, that's right.
Was she from the regional blood transfusion service at that stage?
Yes, regional transfusion centre, but she also had slight involvement with paediatrics, I think.
Dr. Hutchinson.
I can't remember him.
Don't remember him. Dr. Barnard.
Dr. Barnard.
Dr. Barnard.
Yeah, he was a hematologist at St James's Hospital.
And Dr. McAvoy.
Dr. McAvoy was at Harrogate, and he was one of the very senior hematologists, a lot of experience and very wise.
Can you recall whether in those group meetings, anybody from Sheffield would attend? Because of course Sheffield was a reference centre, wasn't it?
No.
There was no one from Sheffield there.
No, actually, and Sheffield was always considered competitor in terms of transfusion centres with Leeds. But no, we wouldn't have. That was a different region.
And thinking back to those meetings, it seems from the minutes and documents we've got, and we'll go to some of them during the course of your evidence, but that the issues that were discussed in that forum were allocation of NHS product from the Regional Blood Transfusion Centre, regional contracting for commercial products, treatment policies, and so on. Does that sound right?
I think that's a simplification. Yes, that's a summary. You're right.
And so, what do you recall the forum? What do you recall being discussed at those meetings?
Well, they discussed what you've just stated.
Yes.
That what our requirements were. But I think they could have done better. They could have been more detailed. And for example, in those minutes, it'll say what we required and what we were likely to use, and what the overall requirement would be. But it doesn't actually talk of stock control.
Well, we can come to some of that detail when we look at the documents. And then just moving through as well, you were a member of the Haemophilia Society, but you never had a role on their medical advisory panel or any other such advisory panel.
No, all directors were made members of the Haemophilia Society. But I did have a few articles printed in there. I think you got some of them.
Yes.
I mean, we might have had one or two small grants.
And then moving on then to ask you some questions about the facilities and services at the centre itself, and you've already given some evidence in relation to that. I think you described that you only had 4 beds when you first started.
And even worse, gone.
Well, what were the facilities like in terms of the physical, in terms of bed space, and where the unit actually, what centre it actually was when you first came to Bradford in 1978?
You see, in terms of haemophilia care, we seem to concentrate on concentrates and treatment. But haemophiliacs were patients, and we were, the haemophilia centres were often they're best friends because they spent a lot of time with us and they came to know us. The facilities in Brantford, when I got there in 81, abysmal, terrible. We used to use cryoprecipitate, which was made by the blood bank. They didn't have any physical space where they could actually be treated. And it was really, if there was space left over from treating cancers and so on, they might have to be seen in the lab. There was no clinical area one could look at. They would have to come into the laboratory, into my office. Offices were in the laboratory with the microscopes. We often had to see them there. We often had to see them in chairs outside. We often, I mean, it was terrible. And as they were getting cryoprecipitate, they often had to stay in the hospital for a while, you know, a few hours at a time. They were very disabled. I think that's been mentioned a few times by other directors, how disabled they were. And really, the whole thing was awful. They were not being treated like proper human beings. You know, the cancer patients were at better facilities. The focus was on malignancies, cancers, more emotive. And it was very, very sad. And
you've described how you built a unit. So until the time when you built a unit, was that the position? There was no treatment room, nowhere for anyone with haemophilia to be treated?
No, what I had to do, because I couldn't get anywhere with the trust, well, there weren't trust then, were there? There were hospital boards or whatever. I got health and safety people, and they put a notice up on saying that this place wasn't fit to treat people, you know, to look at patients. And I thought that might do the trick because I wasn't getting anywhere. Well, there was Crown immunity at that time. They couldn't have cared less what the health and safety people said. It wasn't the hospital management worry about that. But anyway, after really...
When was that? When was that?
That would be like 84, I think, around about that time. Which made me unpopular, by the way. I was never popular with managers. But anyway, they made me a little room with a skylight. This was before our unit was built, you know, and that was a big step in the right direction because we could put somebody there, give them privacy, you know, counseling, talking at time, etc. But that was before we built the unit.
So when do you think you got that room, that treatment room that you could use for treatment and counselling?
I think it must have been 84, 85, because the unit was built... 90, yeah, that was in the early 90s. But so it was a bonus just to have a place, you know. But I think the overall message is we think of haemophilia with concentrates, etc., but we forget that they needed all the other supporting things to help them be treated like normal human beings, you know.
And so when you arrived at the centre in 78, were there any joint clinics with dentists or...
No.
Or any, it was people came in for their haemophilia care and that was it?
Nothing really at all. So when I got appointed, I started recruiting. Remember, we weren't reference center. We weren't given resources. You know, we had to fight from within what the hospitals had. And we were very, very lucky to have some incredibly great people. You know, Adrian Minford, who was never trained as a hematologist, he helped to take up children and start learning about hemophilia, you know, bleeding disorders. We got a community dental surgeon, Hugh McCarthy. He wasn't getting paid extras and so on, but he joined us and he started. They had no dental care. Hemophiliacs didn't have any dental care because the dentists wouldn't touch them with a barge pole. You know, they wouldn't come anywhere near. And so Hugh McCarthy was a community dental officer who took them as part of his job. You know, incredible. And then we had Sister Pauline Sharp, who was a dermatology sister, but when I had 2 beds on her ward, she started taking interest in hemophilia. And we got her gradually trained up to become a nurse specialist. All, again, no extra resources, again, from within our own resources. And then we had Brian Hamilton, orthopedic surgeon. Again, he gave up his own time to come to our clinics and started looking at the joints, etc. So, and then we did get one resource from social services, which was they managed to give some time for a social worker who was trained as a counselor. So I think we were the first in Yorkshire to have somebody who was sort of dedicated doing the social aspects, you know, and so on. But much later than when we had the unit, obviously the Leukemia Fund started funding various things that the haemophiliacs could use. But yes, we built up a team and started clinics, dedicated clinics, from, again, within our own resources. Otherwise, the hemophilics used to come to a general hematology clinic. There may be 50 or 100 patients, and they would be at the end of the queue, you know, because we had to decide what blood tests they had as well, you know. So it was quite a struggle.
Henry, can we have up HSOC 002093? Page 8. Is that the wrong reference? HSOC 002093. That's not got enough digits in it. It must be 3 zeros. Try this. HSOC 00200293. This is that the right? You got that? In fact, can we show page 1 first? So this, and go over to page 2. This is a publication, I think it says at the bottom there, papers taken from an international symposium on HIV, haemophilia and community held at Bradford University on the 23rd and 24th of April 1987. And then if we go to page 7, we can see a paper by you, Advances in Haemophilia Care. And if we go over to page 8, there's a diagram on the right-hand side. We can just go into there. And you've set out the services in 1987 at the centre. And you've got there the haemophilia sister, and that's Pauline Sharp, is it?
That's right.
And you've described consultant haematologist and senior registrar. So that's obviously you and a senior registrar. And then the consultant orthopaedic surgeon and a physiotherapist at that
That's
stage. Right. Social worker and counselling, and you've described, I think in your witness statement you say you had a social worker stroke counsellor for a few years.
That's right. Andrea Breach.
And from another document that you provided to the inquiry, it looks like you were about to get the social worker at the end of 1985. Does that sound about the right sort of time?
Yes.
And then you've described the dental surgeon and Dr. Minford, the paediatrician. Can you recall, we know that was all in place by April 1987, you arrive in 81, centre director in 82. Can you recall how long it took you to get up to this service?
I can't give you exact times, but it was like completing a jigsaw, you know, bit by bit, whatever we could get. These were not working exclusively for the centre because they had their own jobs and so on. By the way, I didn't mention, but we had a very good physiotherapist who, from their department, started taking an interest as well. But what we had here was, the big talk then was comprehensive care. So instead of reference centers, they should have called them comprehensive care centers. Reference means you refer, don't you? You get advice, etc. But even the reference centers didn't have this model. And we were putting this forward that this is how they should be treated, not exclusively, but because you couldn't do that for 40 or even 100 people with bleeding disorders. But this was what I would have called an ideal model, which we were trying to attain, and which we did largely, purely because of goodwill from a lot of very good people in the hospital. But this was what we had set up. The conference really was to put this forward, and I think there are some other papers in there where I think Professor Tuddenham attended that as well, and Professor Zimmerman from La Jolla in California, who's a very great man, great scientist. But I think you might come to that, because not everybody had this journal, by the way. It's a Bradford printed journal.
We have a statement from Dr. Minford, and in his statement he says that he, as you've described, he came to work with you. He was a consultant paediatrician, no training in haematology, but he came to work with you to help you in your clinics with the children. And he describes having joint clinics with you once a month from between about 1983 to about 1986. And thereafter, he then went and took his children patients to a separate outpatient clinic where he managed them on his own. Does that accord with your recollection of how you divided care for the children with haemophilia at that time?
Absolutely. That would be correct. But, it's a great commendation that here's a pediatrician that takes on a completely new area of work, which is full of controversy. And it's amazing. And it's until recently, he's been traveling the world and giving talks on protein C deficiency, etc. His interest has been maintained. Great man.
And so, how frequently did you have in that early 80s period? How frequently were you having clinics for adults? Was that once a month as well?
The comprehensive clinic was once a month. Now, we used to see people all the time because the way I worked was I was accessible to any patient at any time. In my office laboratory, where I was, I had an open door policy, literally accessible, and accessible on the phone 7 days a week. It was no 7. That was, but the hematology clinics we had twice a week, which they had access to as well, particularly on Monday afternoons. But the comprehensive care model was once a month, with all these people trying to get involved on that particular day.
And so if people needed to come and have treatment outside those clinic times, where would they come and how would they be treated?
They would ring my secretaries or the laboratory. Quite often the laboratory, because laboratory prepared the material, the blood bank in our hospital. And they would inform the doctor on call, or me, but often doctor on call. Later on, Sister Sharp became nurse specialist, so the calls also went through her, and I can't remember exactly now the dates and times. But we were very accessible very easily. But having a good organization, good communication meant that the time it took for a hemophiliac to be treated was shorter and shorter and better. Something I don't think we've talked in the directors, the ones you interviewed before. If somebody had a bleed, isn't the damage done waiting 2 hours, 3 hours before they got their precipitate or treatment or whatever? That causes damage. It causes pain, discomfort. So sooner they get treatment, better it is. And home treatment was great for that. That there was no time wasted before they got treated for a bleed.
So if they were needed urgent treatment during the working week or during the day, they could make a phone call and come onto the you've described, there's was no area for them to come to, but they could come to the laboratory or your office.
Out of hours, they would have to go to the ward.
They would go to the ward, with the haematology ward.
Yes.
And if they needed treatment, in the middle of the night, for example, would they have to go to A&E?
No, that's something I think it was terrible, because that used to happen, and often accidents, mistakes in treating people happen because haemophiliacs went to A&E. I think that was a dangerous area for them, because they were being looked at initially by people who had no knowledge of haemophilia and haemophilia care. But I mean, if they did turn up at A&E, the whole message there was call the hematologist on call, call the doctor on call,
And so patients would turn up on the haematology ward in the middle of the night, would they, if they needed treatment?
We tried to have them not go to A&E.
And in terms of, we looked in 1987, there was you and a senior registrar, and of course Dr. Minford providing paediatric care. But how did the on-call rota work then? Were there quite a few people delivering care to people with haemophilia outside office hours, or was it just split between the two of you?
You see, fortunately, as we developed into a proper training, etc., we had a few middle grade doctors that could be on call, first on call. We tried not to use house officers, which often happens even in reference and in big centers and so on. The house officers were the least trained, but we had middle grade SHOs, registrars, and senior registrars who were better trained. That was accessible to the patients with bleeding disorders. And then we were there, obviously. I couldn't be on call, first on call all the time, but no. I was always there, even on holidays, as Chris would tell me. It's stressful, that.
And so, so there might be, you and your senior registrar obviously couldn't cover all the on-calls, but you had...
registrars and senior officers, yeah.
Who would cover. Did you have any written treatment guidelines at any stage that they could refer to for when patients came in and you weren't there?
Always. But not only that, we made sure that the laboratory, so when they asked for blood products from the laboratory, who prepared the products, the laboratory had a guideline, and we had such good staff that they actually came to know the patients, and they had a book which they would look up, and each patient, we had written down what sort of treatment they should get, what products. I noticed from the previous directors you've had, we tried not to mix the products, because if something went wrong, at least we would know which batch or what was happening there. We tried not to give each patient different batches from different companies. But yes, it was all written down, it was protocolized, and obviously UKHCDO was very helpful in there because they did produce guidelines, and we tried to stick to UKHCDO guidelines as far as we could.
Can you remember when you drew up your first protocol or treatment guidelines for other members of staff to refer to when they were providing treatment?
Now, it's quite interesting in that when I got there, and I have a conscience about this actually, so when I got there in 81, they were using cryoprecipitate almost exclusively. But because we were using cryoprecipitate, there were a lot of centers that were thinking that Bradford was an inferior place, that it didn't keep up with the times, and a lot of patients also felt that we were not keeping up with the times because they were well informed, from society and so on, and from companies, by the way. And they would go to other centers and so on. I have a little problem myself because I was the first one who really to order the commercial products. Now, cryoprecipitate wasn't the best treatment, but as soon as we started having a choice of treatments, we had to have a protocol. And then obviously we needed protocol because mild hemophiliacs and von Willebrand's and so on, the first call would be on DDAVP, it wouldn't be on.
So when you had to have a protocol when you had a choice of treatment. So as soon as concentrates came on the scene, you think that's when you would have drawn up your first treatment
but
protocol?
not only concentrates. When we had DDAVP, that came on the scene. But there was also different. We had different choices between different concentrates.
And so again, so that would mean that you would have to have a protocol.
And
where would that protocol have been kept? Would it have been on the ward?
No.
Would it have been on the ward?
Well, in the laboratory, very important, because they checked. Whenever anybody needed treatment, we made sure that they knew ward definitely, and obviously that the doctors were informed. Well circulated, If in doubt, they rang me, So.
And do you know where they were kept? No protocols have been disclosed to the inquiry. Do you know what could have happened to them, or where we might find copies of those now?
Very difficult, but I think you have from the documents from me is that UKHCDO it does set out a protocol. What the recommendation,
Yes.
the protocol. Protocol is the wrong word.
And we'll come to
It
those.
gives
yes.
recommendations,
Yeah.
and those were the recommendations that would have been given. You've got minutes of the regional meetings where also we state what should be used, and we adhered to it.
Well, as I say, we can come to those in due course. So I think you were describing a book that the laboratory clinicians could refer to when patients came to get treatment. And in your witness statement, you've said that there were effectively two sets of notes. You had your hospital notes, and then you had your own records of treatment that you kept. Is that your own records? Is that what you were referring to when you described the book?
No. The blood bank had a book with each patient's name and what products they were getting, and also at the top it would say what was the recommendation was. That was one. The hospital case notes, which are an absolute mess, they were hospital notes like all other notes. If he wanted the hospital notes to look up treatment, etc., it could take 2 hours to 2 days. It could. So we kept our own what we called green cards, and they were kept in my room in a filing cabinet that anybody could come and pick it out. And that actually mentioned what treatment they should get and the record of what they were getting. And also the clinical notes were written on it. That was accessible almost immediately. Okay, so there are three different areas.
And was everything that was on the green card also in the hospital notes?
Well, they would have, if anybody was seen as an emergency or somebody wrote in the green card, it may or may not have gone into the main case notes. But if they were seen in the clinic, then there was always a letter. There was always a letter in the case notes.
Was the green card system the system in place until you retired in 2009?
Yes, it was. Yeah, but now I think they've computerized everything.
So when you left in 2009, your office still had that filing cabinet with all of that information in it.
That's right. I'm not sure what records were destroyed and what weren't, but I think there's a lot of material that's you can't find it.
And just we'll talk about home treatment in a little while, but just while we're on record, when people were on home treatment, what was the expectation of them in terms of keeping records and sending you information about their treatment?
If they didn't keep records, they would not get home treatment. So we kept records of what was issued, but we kept records of what they brought back. Otherwise, they wouldn't get the next issue. That means they had to note down the bleeds they had and why they had the factor 8 of, and they had to bring back the needles. They were given appropriate containers. So all those records were kept just as if they were being treated in hospital.
And that would have been entered onto the green card system?
That would have been entered in the blood bank records because they couldn't exchange. It was the blood bank staff that issued new bottles and home treatment packs or needles or whatever they needed.
I'm just going to ask you some questions now about patient numbers and treatment policies over those years in the early 1980s. Before I do, can I just ask whether or not you recall whether or not you were given any guidance or training by Professor Turner when you were working with him about treatment policies?
I don't think he had treatment policies, except that we were using cryo almost exclusively. Very little commercial product was used, and I think the commercial product that I see on the returns, which I didn't know until I saw those returns, may have been hemophiliacs were able to travel once they could carry factor 8 with them. You know, they were unable to travel otherwise. And I think sometimes if they were in Bradford, they would bring the bottles and get treated, and that would be recorded. But Professor, he was quite old-fashioned, and he believed cryoprecipitate was okay.
So should we look at we'll look at the 1976 return. So this is before you arrived, but it's under his directorship. Henry, it's HCDO 5037 _002. And we can see there, 1976, Professor Turner, total number of people with haemophilia treated during the year, 18. And then he's given primarily cryoprecipitate, and he's given a small amount of cryobuline. And that was more or less the picture, was it, when you arrived in 1978?
Now, this cryoglobulin may have been somebody, a traveler, a tourist, you know, somebody going through Bradford, carrying his own material.
You think that's unlikely that would have been prescribed by Professor Turner?
Completely, very unlikely. Actually, he would not have known what cryoglobulin was.
So we don't have the returns up to 1981, but are you pretty confident then that up to the time when you stepped into acting as acting director, it would have been primarily cryoprecipitate?
Absolutely.
And then when you took over in 1981, before you were appointed director in 1982, were you able to make any changes to the treatment policy at that stage, or did you feel you had to wait until you appointed director?
Well, this is the bit that I've tried to remember, whether, because there was a lot of pressure to change, you know. I mean, so I can't recall, but I was responsible for ordering the first concentrate, and whether I did it through pharmacy or blood transfusion service, I'm not sure. But it may have been in 1982, I think, that may have happened.
Can we look then at the 1982 return? Henry, that's at PARA 603.
See, by this time, there was a large amount of commercial factor being used in the country. Actually, there was more commercial products being used than NHS material, you know, so we were quite late on the scene, really.
PARA 603. That's definitely the right. Can you access PARA 602? Sorry. Yeah. It's supposed to be uploaded. I think they were the documents that were sent this morning. No, I can't hear you. It's not. They start from 5. Right, well, we don't have that document, so we may have to come back to that. I note the time, sir. I wonder whether now is a good...
It might be convenient if we took our morning break now, so that the document can be located, and any other documents that you might want to refer to, you can just check are on the system.
Thank you.
Professor, the rule that we operate is that when you're giving evidence, you can't talk during a break of any sort, any length, to anyone at all about your evidence. Talk about anything else you like, but not about your evidence, either what you have said or what you think you might be asked to say. Can I ask you to observe that, please? And we have a break in the morning. It's always a lengthyish break because we have to make sure that people keep social distance. And it will be back in just under half an hour, 11:25. So 11:25, if you please.